I think that in the relatively near future, at least lutetium PSMA-617. So I would categorize that as a beta emitter with a small molecule. I'm pretty sure that's going to be approved for kind of heavily pretreated mCRPC. And I think the initial kind of next step is already being done, as I mentioned, with multiple phase 3s of similar types, although one of these is an antibody that's going to phase 3, but beta emitter PSMA-targeted radionuclide therapy, moving to early lines of therapy. So I think we've already now proven that in late stage it can work either head-to-head against Cabazitaxel or following Cabazitaxel. And looking earlier, that may be alone, or some of the trials are in combination with hormonal therapy, so which makes a lot of sense. So that I think is the initial kind of a next step, because most doctors and most patients want to use it earlier, but we have not proven that it definitely works in that situation, or that it's safe in that situation, because there can be long-term toxicity from radiation, just kind of generically. So that's one unanswered question. Another unanswered question is, what's the optimal patient population? So many have taken for granted that PSMA positivity by imaging and kind of quote theranostic type of platform is much better than treating kind of anyone. I think that's true. There was a publication earlier this year that points towards that, but it also points towards the possibility of those with poor imaging still a subset, smaller subset, can still respond. There's some evidence about DNA repair defects that maybe it's going to be better, which makes sense in terms of radiation. So I think there's some unanswered questions about the optimal patient population. And then very few have addressed the optimal dose or schedule. When I say dose, I'm talking about as from an oncology point of view, what goes into the vein, the administered dose, not from a radiation dosimetry point of view, which is another unanswered question. Can we individualize treatment? I think it's great. We've done the initial important part, showing that it works kind of as a quote medical oncologist. I can give us a flat dose and it looks like it's safe and it will work. But I think that we can further optimize the therapy in terms of line of therapy, different combinations, patient selection, and possibly either individualized dosing or maybe a more dose intense type of an administration like we do with external beam.